presentation now.
Okay, thank you, Amaya. I'm going to talk about trials in sedation or neuro in liver. And 1 minute, I couldn't get the slide. Next slide. Okay. Uh, I'm going to talk three trials, non-SEDA, SPICE-3, and MODEST trial. And first one, non-SEDA trial. This is the trial they conducted to see the impact on 90 days mortality among the patients in ITU who were mechanically ventilated patients. They compared with no sedation and with light sedation with daily sedation break. So they just did the trial because of this background, because there were several major trials demonstrated reduce the amount of sedation will give good outcome to the patient. So they just want to make sure that. And the similar study was done in a single center randomized control trial that showed more ventilator free days in no sedation group. So they just want to make sure this. So they did this trial is in an expanded manner. And the study design was is a investigator-initiated randomized clinical group, but no blinding of investigators or patients or relatives. But this was done among 8 Scandinavian ICUs from January 2014 to November 2017. And population was inclusion of this population more than 18 years, and intubated patient it was within 24 hours and expected to ventilated more than 24 hours. And exclusion groups with severe head trauma and patients with status epilepticus and therapeutic hypothermia and on admission coma or brain death. These are the patients on exclusion. And same time they exclude the patients who are admitted from some other ICUs. So they stayed more than 48 hours in that ICU. And around 710 patients were included in this trial, 354 in a no sedation group, and remaining patients were in the light sedation group. And around these patients, 68% of them were medical admissions, but more or less both groups were similar apart from the Apache 2 score, only 1 point higher in non-sedation group. Otherwise, they were similar in these both groups. And the intervention group, they didn't give any sedation, but they gave morphine boluses for analgesia. In the control group, they gave continuous sedation with the aim of RAS -2 to -3. But first 48 hours, they gave propofol, following that midazolam infusion. But every day they did the sedation break, every day morning. The outcome of this study was primary outcome. There was no significant difference in 90-day mortality between no sedation and light sedation group. And in addition to these primary outcome, they found some other secondary outcome as well. No significant difference in days under death, ventilator-free days, ICU days, days free from coma or delirium, highest Dreyfus score to assess the renal function, renal status, and accidental extubation requiring reintubation within an hour, but no significant difference at all. And but in no sedation group, they found significant reduction in DVT or pulmonary embolism. But same time, significant incidence of more accidental extubation and removal of other equipments in no sedation group. In this study, the strength of this study, we can tell clinically important question. This is a important question, and in 3 countries they did in 8 ICUs, and they did follow up very well. And the weakness of this study, there was a significant crossover from no sedation to light sedation group. And same time, this is a non-blinded assessment. And in no sedation group, the patient's psychological well-being was not assessed. And in conclusion, we can tell no differences in 90-day mortality between two groups, but there is a benefit in DVT or pulmonary embolism episodes in no sedation group. And same time, there's a risk of increasing extubation and removal of other equipments. So learning points from this study, we can continue the light sedation with target RAS -2 to 1 with daily sedation break. That's good for the patient. And same time, we should avoid over-sedation. And in future studies, we should think about to study about the psychological effect on patient if patient with no sedation, and same time nursing workload also. And this is the first trial. And the second trial, I'm going to talk about MODEST trial. This is a trial. They evaluate the administration of simvastatin in acutely ill, mechanically ventilated patient in the ITU. Is there any effect to prevent or treatment of delirium in these patients? So this is the clinical question they ask. Is there any benefit to reduce the incidence of brain dysfunction such as delirium or coma when we administered simvastatin early? But background of this study, because in critically ill patients, there's a high risk. That means getting delirium is more common as 80%. And same time, we don't have effective pharmacological agents to prevent or reducing the delirium. So that's the other one. And in the critically ill patient, when they analyze the CSF sample that contain high concentration of pro-inflammatory cytokines, so they just think that giving the anti-inflammatory drug statin, is there any benefit to reduce this brain dysfunction? And design of this study, this is a single center randomized controlled trial, and they use identical drugs as placebo and active drug. Both were identical, and healthcare workers and patients were blinded. They don't know which drug they are taking. And then coma, that was assessed every 4 hours by RAS score, -3 to -5. That's the target RAS they aimed. And the delirium assessed by CAM score, that was assessed 12 hourly. And this study is a single center study which was conducted February 2013 to July 2016. Inclusion criteria was the patients who were mechanically ventilated within 72 hours of critical care admission. Exclusion was less than 18 years old, pregnancy or breastfeeding patients, allergic to statin, and patients who already on statin, they were exclusion criteria. And intervention, in the intervention group, they gave 80 milligram of simvastatin as soon as possible early after the ITU admission with the mechanical ventilation, and following day, in the midday after, every day midday, they gave this simvastatin, NG or oral, whatever the route. They compared with the control group, and outcome, there were no significant difference in the free from delirium or the free days of coma in the simvastatin group. And they just check other secondary outcomes as well. No significant difference in delirium free or coma free day at day 28, and incidence of any delirium, ventilator free days, organ failure free days at day 28, all causes mortality at 6 months, median length of hospital stay, cognitive decline, no difference at all in both groups. And the conclusion from this study, early administration of simvastatin in critically ill patient, we don't have any significant difference in the number of days free from coma or delirium. But the strength of this study, we can tell this is a well-constructed trial and reasonable potential. We can generalize the result to the other population, but weakness, we don't know how we can extrapolate these results to other population, and same time these are relatively short duration of administration of this drug. So these are the weakness. And the learning points from this trial, even though it's a well-designed conducted trial, this mentioned no benefit from simvastatin to prevent or treat early delirium. And we should think about the further studies with different regime or different population for the future development. The third one, the SPICE-3 trial. This trial, they just check the early administration of dexmedetomidine in a critically ill mechanical ventilated patient with compared to usual sedative agents. Is there any effect on 90-day mortality? That's the trial they did. The background of this study was we don't have ideal agent to keep the patient comfortable and safe in the ITU with ventilator support. So they just want to know if there is a good ideal agent to find out. And same time, we have several options for sedation. And in the previous some studies, they mentioned dexmedetomidine has shorter times to extubation and high number of days without coma or delirium. That's why they did this trial. And this trial design is a randomized control trial, is an unblinded trial. It was conducted among 74 ICUs in 8 countries from November 2013 to February 2018. Around 4,000 patients were included in this study. The inclusion group, the patient who admitted to ITU with the critically ill, mechanically ventilated patient, but we expected they will ventilated for at least 48 hours and needing sedation. These are the inclusion criteria patients. Exclusions were less than 18 years and ventilation more than 12 hours before we started the trial, and acute primary brain injury. These are the exclusion patients. In the intervention group, they started dexmedetomidine initially 1 mics per kg per hour. The range is 1.5 mics per kg per hour with the target, the prescribed RAS. According to the prescribed RAS, they adjust this dexmedetomidine infusion. And if it is not achieve the sedation with this dexmedetomidine, they could start the other sedative agents. In the control group, they were given propofol, midazolam, and other sedatives. But if it is not adequate, they could able to give the dexmedetomidine. And same time, the agitated delirium, they could give the antipsychotics. The outcome from this study, they found the primary outcome, there were no difference in 90-day mortality among dexmedetomidine versus usual sedative agents. In the secondary outcomes, also there were no significant difference in death at 180 days, an assessment of cognitive decline, assessment of quality of life, and institutional dependency. But in a 1-day difference in the ventilator-free days and coma and ventilator-free days to 28 days in the no sedation group. And but in this study, they found some adverse outcome of dexmedetomidine than the normal sedative agents. They found bradycardia, hypotension, and asystole. And so from this study, the conclusion was dexmedetomidine as a primary or sole sedative in ITU in the ventilated patient not result in lower 90-day mortality. And strength of this study, this was the external and internal and external validity, and it's a very important question. And this is not previously studied, and same time, they studied adverse effect of this dexmedetomidine as well. And same time, with the primary and secondary outcome of these ventilator-free days and delirium, also they examine. That is important management implications. And the weakness of this study, even though with the um, dexmedetomidine, 11.5 percentage, they in the usual sedation group, they received the dexmedetomidine in addition to the usual sedation. And um, only the slight 1 day difference in the ventilator-free days and delirium, and dexmedetomidine is more expensive drug. And the learning points from this study, the dexmedetomidine is not a sole or primary sedative agent in the ITU. So we can consider using it in agitated or delirious patient, or when wean from the usual sedation, or when we try to wean off from the ventilator, we can use this dexmedetomidine. And same time, we should monitor uh, about this adverse effect as well. Thank you.
Thank you, Sharmali. So, does anyone any have doubts? Any questions or suggestions? Sharmali, that was a very good appraisal also, and covering the learning points. Okay. Is it okay if you can just quickly scroll the slides back? I
Okay, sure. Which one you want?
just about the trial and the way they conducted the trials. So I'll just go on quickly telling some learning points that I'm going to speak. Okay,
Yes,
the first trial.
first one. Okay.
Yes. So I think this is the modest trial about some early
This
administration.
is a non-SEDA. You want a modest trial?
Can we go back?
This is the first one.
Is this
And this is the first one. The second one is the modest trial.
okay? Okay. One is which one? Say, I forgot the name of the trial.
So
Anyway,
regarding what simvastatin or
yeah, yeah.
dexo, which one?
The name of this trial.
The three trials. This is a modest trial regarding the simvastatin.
uh,
And the first one, non-SEDA, is the no sedation and with sedation. Other
Yeah.
one is the
you- Can you open the non-SIDAS trial
uh,
and let me get back to you? I will be just discussing about the learning points because even I'm not good at critically appraising the way Sharmali did it. It was nice and meticulously done. Uh, non as far as non-SEDA trial is concerned, one of the basis of the trial goes that there was once upon a time in the olden days abuse of sedatives. That is, there would be use of polypharmacy and use of many sedative agents at one go, and as well as muscle relaxant. So that increased the duration of ventilation, then development of critical myopathy and other chest infection. So some of the, although it showed that there were no significant benefits in quite a number of primary and secondary outcome, some of the main benefits that it did show was that we are rationalizing now the use of sedatives, as well as it also helps in reducing the incidence of delirium, and at the same time the overall outcome, although it is not studied in detail, is like how shall I put it, an indirect marker. Maybe it might be good if we give the patient some sedation holiday, rationalize the use of any sedative agent, and try to minimize the dosage also. But at
mhm.
you need to have a very strong monitoring to ensure that the patient lies in that sedation target range. Then the second modest trial, I was working in cardiac anesthesia many years ago. So at that time, there were many trials which showed pleiotropic effects of statin. When I'm saying pleiotropic effect, it means that These are the side effects that cannot be explained by the pharmacokinetic or pharmacodynamic action of that drug. So some of the side effects that were seen, I'm sorry, not side effect, beneficial effects that were seen in of statin that were seen in cardiac patient was that the incidence of aortic atheroma, then carotid artery atherosclerosis, stenosis, I mean, and the incidences of myocardial infarction over a period of time significantly reduced. But it was not an acute reduction, it was with chronic use of statin, as well as there was significant improvement in renal function. So it was postulated that statins are to some extent neuroprotective or nephroprotective. However, this particular trial shows that statin does not per se has its own neuroprotective effect. That's what I can say. Otherwise, it would have been helpful in reversal of delirium and coma for us. Yeah, but it long-term basis wise, the statins can show some kind of other benefits for which we can use it, like nephroprotective agent, then preventing atherosclerosis and related complications. The third trial was on dexmedetomidine, which is about that it does not significantly reduce delirium in ICU. But what it actually tries to say is that if a patient is already sedated and ventilated, at that time, using dexmedetomidine as sole agent should be used with caution rather than saying that no, dexmed is absolutely not effective. That is what I can learn from this these three studies.
They said the dexmedetomidine as a
Hmm.
sole agent they are not advising, but we can use with the patient agitated, or if you are going to wean the patient, in that point we can think about that. No?
Correct.
But otherwise, with other sedative, with the propofol or whatever, we can use the
We
dexmedetomidine.
can add dexmedetomidine, and we have to monitor closely because dexmed has only one major side effect, that is bradycardia and associated problems. So
Hypotension and asystole also can happen.
yes. Now, Sharmali, just to add one more thing, there was one trial in, not a trial, a study in cardiac recently, which showed that dexmedetomidine can also cause hypertension. And the basis that they have given is if a patient has a very good cardiac function and if the patient is not decompensated, so because of bradycardia, the cardiac output falls. Hence, initially there is a fall in blood pressure. But being an alpha 2 agonist agent, it may have some alpha 1 agonism. That is what was postulated. But always remember hypotension is a well known side effect of Dexmed.
Yes, even in this trial they mentioned
Yeah,
hypotension, bradycardia, and asystole 3.
yes, that's true. Absolutely true. And even that is why if you are going to use it with caution. Otherwise, it is equally a very good drug to use. All right. Does anyone have anything to add or whatever you'd like to share your learning points? So I think shall we go ahead with the next presentation by Anindya?
Thank you. Thank you very much.
Thank you very much, Sharmali. That was a really good presentation.
Yes,
But
thank you.
I have sent the feedback links to both Anindya and Sharmali. If everyone can fill it up and send it back. Yeah. So Anindya, if you can start sharing your slides and you can start presenting. Over to you. Anindya, we cannot hear you. You're muted, Anindya.
Hello,
Ani-
May. Is my screen visible?
yeah, your screen is visible, but you were
Yeah,
muted. Now we can hear you well.
yeah. Okay.
Over to you.
Yep. Thank you. So hello, everyone. So my today's weekly teaching topic is on vasoactive drugs and monitoring of invasive blood pressure, and a bit about vascular devices that we use in the ITU. Um, to be fair, these are very broad topics. I've tried to compress and present them in a way that would kind of give a good grip of what we deal with in day-to-day basis in the intensive care. So first of all, what I would like to start with is vasoactive drugs. So the vasoactive drugs are basically pharmaceutical medications or drugs that have effect of either increasing or decreasing the blood pressure and or the heart rate through vasoactivity, specifically acting on receptors in the system, which are the adrenergic, dopamine receptors, vasopressin receptors. The main aim is to improve the systemic hemodynamic variables of our body system so that we are ultimately able to attenuate derangements in organ perfusion and achieve oxygenation during different types of shock. The receptors that are mainly working towards this are the alpha 1 and alpha 2, beta 1 and beta 2, dopamine and the vasopressin receptors. As you can see, I kind of have highlighted the locations of the specific receptors and as well as their actions, which you will see um, next in the few consecutive slides. According to the different vasoactive drugs, they have different effects on the different receptors. So mainly the alpha 1 is present in the smooth muscle wall and the vascular wall, and as well as the cardiac muscle. Alpha 2 in the central nervous system, arterioles, and the pancreas. Beta 1 in the cardiac muscle, the SN node and AV junction. And beta 2 in the skeletal, vascular, and bronchial smooth muscles, along with liver and uh, cell membranes. Dopamine receptors are present in the kidney, heart, splanchnic organs, as well as cerebrovascular beds, and vasopressin in vascular smooth muscle. The actions vary from vasoconstriction to vasodilation according to the receptors, which we will go in a bit detail later on according to the class of drugs. The classification, it can be classified in two ways. One is as vasopressors and another as inotropes. The broad classification that we would like to go on is the classification according to the chemical components or chemical derivatives, broadly classified as catecholamines, which have adrenaline, noradrenaline, dopamine, dobutamine, isoprenaline, and dopexamine, phosphodiesterase inhibitors in milrinone, ambrinone, and levosimendan, calcium sensitizers as glucagon, levosimendan, pure vasopressors as phenylephrine, metaraminol, ephedrine, vasopressin, steroids, and the others including digoxin, calcium, thyroid hormones, and methylene blue. To have a better understanding of the pharmacology of the different medications, I think this is a chart that would be useful. If we, in broad terms, it has effects on the heart rate, cardiac output, systemic venous resistance as SVR, peripheral venous resistance as PVR, and CVP as central venous pressure. So as you can see, we have in the table denoted each medication and have denoted what effect it has. And many of the medications don't only affect only one receptor, they can affect both the alpha and beta receptors concurrently and produce effects simultaneously with the heart rate as well as cardiac output, as well as the venous return and venous resistance. Mm, so the main drugs or the commonly used drugs, for example, phenylephrine is purely an alpha receptor uh, medication, which has a main effect on increasing the peripheral and systemic venous resistance, as well as whereas norepinephrine acts on both alpha and beta receptors and works by increasing both the venous resistance as well as heart rate and cardiac output. Um, it this from These are mainly given as infusions through central or peripheral lines in the intensive care. But what we can also give many of these medications as what we call as push dose pressors or bolus dose pressors, which are just bolus drugs of these medications, which are given urgently to manage hypotension, given in acute settings as like someone coming in with a shock or just post cardiac arrest. The commonly used push dose pressors are epinephrine and phenylephrine, and their onset of action is within 1 minute, and duration of 5 to 10 minutes. For epinephrine, phenylephrine is 10 to 20 minutes. They do have some adverse effects, epinephrine mainly causing tachycardia and rebound hypertension, and phenylephrine causing bradycardia and rebound hypertension. As you can see, the table kind of described what was happening. So this is much more of a simplistic picture of how the drugs react, or what we say as vasopressor as the Avengers. So as we have compared them with the Avenger superheroes, which we are mostly known of right now because of the Marvel movies, norepinephrine is the first line. So that's why it's described by Captain America as the first Avenger. And as you can see, acts on all the three receptors, alpha, beta 2, and beta 1. In the alpha 1, it increases systemic venous return and blood pressure, and beta 2 protects the blood flow to organs. And by acting on beta 1, it increases heart rate and cardiac output as well. The second in line is the epinephrine or adrenaline, which also acts on alpha 1, beta 2, and beta 1. And has the same effect on of increasing ionotropy, heart and cardiac output because of its beta 1 actions. And in alpha 1 causes a systemic venous return increase, as a venous resistance increase, along with blood pressure increase and bronchodilation because of the beta 2 component. Third, we go for the phenylephrine, which is the peripheral pusher, which increases this systemic venous return, venous resistance, as well as blood pressure. And it may, for this alpha 1 action, it may cause reflux bradycardia as well. Dopamine in low dose acts on beta 1 and dopamine receptors, causing renal vasodilation, as well as increases heart rate and cardiac output at mid-range. The cautious thing to be aware of during dopamine use is to be aware of the tachyarrhythmias. And as you can see, the low dose dopamine actually represents Dr. Bruce Banner, who when gets angry or when in high dose becomes the Hulk, or which acts as a pressor to increase the blood pressure. That is acts on both alpha 1, increasing the systemic venous resistance, as well as the blood pressure, causing vasoconstriction. And last but not least, we have the dobutamine, which is commonly used for acute heart failure or cardiogenic shock, and is used mainly for, and has effects on mainly beta 1 and beta 2 receptors. In beta 1, it causes increased cardiac contractility and heart rate, which has a significant effect on the cardiac output. And in the beta 2, it causes decreased systemic venous resistance as it decreases the afterload by vasodilation. And last but not least, we have some vasopressins, which are commonly used as an adjunct to norepinephrine, and has effect on the vasopressin receptors on the system, which causes vasoconstriction, as well as increased water reabsorption from the kidney tubules. So this was all about the vasoactive drugs. I'm not sure why did not they represent Black Widow. So if anyone has any suggestions what drug could be represented by the Black Widow, please feel free. So next on, we go on for invasive blood pressure monitoring and vascular devices. So the vasoactive drugs can bring about changes to the blood pressure or hemodynamics of a patient really quickly, and might need monitoring to so that we can titrate the drugs accordingly, as the changes are quite rapid. So typically it is done by doing arterial line catheterization or arterial line BP blood pressure. So what happens is that when the arterial pressure waveform, which is detecting in the monitor, it represents the left ventricular contraction through the aortic valve and the vessels, which is relayed through the catheter and then up to a column of fluid along the transducer, and which helps us to relay it as a waveform electronically on the monitor. So the main uses of the arterial line blood pressure is for direct and continuous BP measurements, and can be also used for easy arterial blood draws. If someone is needing constant blood tests, we can also use the arterial line for it. And hyperinized saline pressure bag also makes it sure that there is no clot formation or occlusion in the line of the BP. And just to be aware, arterial line blood pressure systolic would be a bit higher and diastolic a bit lower than the non-invasive blood pressure that we would have from the patient's readings. So this is kind of just the pictures of what we tend to find in the arterial line set in our department. The arterial line set comes in the green packs as shown by the cursor right now. We would need some chlorhexaprep, some lidocaine, and some 5 ml syringe for the lidocaine, as well as sutures. And in the green pack, we have these three components. One is the still needle, the guide wire, and the arterial line itself. The common sites for the arterial line insertion would be the radial and or the brachial arteries usually. So as you can see, if we take the radial approach, after cleaning and making sure that it's well dressed and aseptic, we would like to introduce the needle at a 30 to 45-degree acute angle, and in a way so that when we introduce the guide wire, it goes parallelly into the vessel once it enters the vessel, and then we can slide in the art line itself, which goes parallelly to the vessel, and then we can connect it to the transducer to get the reading. So there are some points to be aware of while doing the outline itself. It is to always to make sure the guide wire is visible. We can send off a gas sample or to ensure that the sample is arterial sample itself, and as well as before doing the outline, we have to make sure that we have checked the clotting and make sure the patient has not received any kind of low molecular weight heparin or unfractionated heparin. This kind of shows how the components of the transducer and how the transducer works. So as you can see, the pressure and the fluid level of the transducer causes a waveform to form on the monitor itself. And the waveform itself can give us a lot of information, ranging from heart rate, systolic pressure, pulse pressure, and as well as whether someone has any kind of valvular deformities. So the waveform actually has two limbs, which we say one is the anacrotic or the upstroke limb, another one is the diacrotic limb, and another of and between the upstroke and the diacrotic limb there is a diacrotic notch, which is present here in the model. There are three phases. One is the systolic phase, which is the rapid increase in the pressure to a peak, followed by rapid decline, which kind of corresponds to the left ventricular ejection and opening of the aortic valve, which is represented in the systolic phase. The diacrotic notch is because of the vascular resistance of the peripheral vessels, as well as some component of aortic valve closure. And the diastolic valve represents the run of blood into the peripheral circulation, that is the blood going off from the left ventricle through the aorta. So as we were saying, the wave has 6 components. The first one being the systolic upstroke, which is the ventricular ejection and corresponds to the peak aortic blood flow acceleration. Systolic peak pressure is the maximum pressure in the central arteries, that is the main aorta generalized during the systolic ejection or systolic phase. And the systolic decline is the rapid decline in arterial pressure as the ventricular contraction comes to an end. After that, we do have the diastolic runoff as well as diacrotic notch. The diacrotic notch we have discussed before, and the diastolic runoff is basically when the heart is relaxing and the ventricular is not filling up. And at the end, we have the end diastolic pressure, which may vary in different cardiac conditions. If you correspond to the ECG tracing in the monitor along with the arterial waveforms, we would see that there is a bit of a delay. Usually in the textbook, it is mentioned about 160 to 180 milliseconds delay with the ECG waveforms. And if you can see with the corresponding R wave, the systolic phase delays about a few seconds, about a few milliseconds. Another important measurement or the value that we tend to derive from the arterial waveforms is the mean arterial pressure, which is the average pressure through which the blood flows through the circulatory system. Mathematically, it is 1/3 of the systolic BP minus the diastolic BP plus the diastolic BP as a whole. The mean arterial pressure is actually a marker for how well our tissues and organs are being perfused. Normal value lies between 80 to 100 millimeter mercury. Anything less than 60 is indicative of that perfusion to vital organs may be compromised. But at present in the department, as well as according to all the regulatory bodies, we target for a mean arterial pressure of 65 or above to say that the organ perfusion is that there is some organ perfusion. Mean arterial pressure may vary from different conditions, along with renal failure of a person is being filtered at the moment, where it ranges. If someone is on the filter, we might target for a bit higher one. As well as for neuroprotective measures, we aim for a higher map of 85 to 90. As we were stating before about the pulse pressure, a very widened pulse pressure can suggest aortic regurgitation, and a very narrow pulse pressure can correspond to its low cardiac output. So if we see variables in the pulse pressure, we can be sure of some kind of valvular anomaly. So the next kind of discussion we're going to have is about vascular devices. The most common vascular device that we use in the ITU is the central venous line, which has a few indications that we can use the central venous line for. One being vascular access, which is not the primary, but is a good access for drawing bloods and giving fluids, as well as for volume loading and provision of caustic medications or solutions. Repeated blood sampling can be done to the central venous lines as well, and as well as introduction of pacemaker or pulmonary artery catheters through the central venous lines. There are some contraindications of central venous line, which would be distorted anatomy, as well as proximal vascular injury and or infection to the site of the venous cannulation. That is, if we have any kind of groin infection or infection in the region of the internojugular veins, then we would typically avoid that. Any kind of bleeding disorders or on any active anticoagulation treatment, and combative patients, because there are risks of the patient pulling the line out and causing massive bleeding and hemorrhage. So the kit that comes in the department is kind of comprised of the components shown in the pictures. One being the triple lumen catheter, the guide wire here, the dilator, scalpel, the still needle, anesthetic needle, as well as sterile drapes and sterile sponges, the dressing itself, and IV caps to secure the ports. Usual sites for the vascular central venous line are internojugular veins, femoral, and subclavian as well. A bit more clearer picture of the components that were shown before. So that's our triple lumen venous catheter, and this is our dilator along with the needles, scalpel, and that's kind of the fixator where we would like to fix it with the skin with the sutures, and dilator as well. The color of the dilator may vary according to the kit that is available in the department. So the central venous line is usually done on the internojugular veins or the femoral veins in the department, and it's ultrasound guided procedure. We have to confirm the site via the ultrasound. The anatomical line mark is kind of depicted on the picture on the left of the screen, which kind of shows where the internojugular vein may lie in relation to the sternocleidomastoid mastoid muscle, as well as the clavicle and the carotid artery, which visualized by the ultrasound would show something of a picture like this, with the internojugular vein being a big lumen and easily compressible under the ultrasound probe, and not being pulsatile. We have to make sure before we do the procedure that we are maintaining sepsis, ensuring that we are gloved, properly gowned, as well as have a head cover. And the ultrasound probe also has a cover, and there's proper draping and cleaning as well of the site. We also have to make sure that all the ports are flushed and locked, except for the port through which the guide wire would come out. And as well as a good option is to check with the clotting factor, so to make sure that there's no clotting derangement, as I've mentioned before in the contradictions. So after introducing the needle and when we introduce the kind of the guide wire, if we try to again recheck the position with ultrasound, we might be able to see the guide wire tip on the internal jugular vein as seen in the picture here. And our main aim is to get the catheter kind of parallel to the internal jugular vein so that the catheter tip can be inserted easily parallelly through the vein. And then that's how we're going to fix it to the skin using the protector, as well as we might be able to send a sample off to check to make sure that the sample that we have received is a venous sample and we are in the vein, not in the arteries. Another way of monitoring of using the vascular device, in this case the central venous catheter, is by monitoring the central venous pressures. But it is a poor predictor of the fluid responsiveness, although it can give us kind of a idea about how some of the vasoactive drugs are working. We do have to make sure that the central venous pressure on the SVC, that is the superior vena cava, and the right atrium would be similar, but would be a lot higher in the right ventricle as it fills up with the blood from the right atrium under right atrial pressure. So the take-home messages from this session is understanding the vasoactive drug pharmacology, specifically of the common drugs used, and the pressor bolus doses of epinephrine and norepinephrine and phenylephrine. Understanding the waveform of the arterial pressure and different map targets when we are seeing the systolic phase and diastolic phase in the waveform of the arterial waves, and as well as to ensure good central line placement techniques. Thank you very much. If anyone has any questions, please feel free to ask.
Questions? Any doubts or suggestions?
Hi, Arya. No.
Hello, Dr. Ferenc.
Hi, can you hear me?
Yeah, yes. Go ahead.
Yeah. Thank you, Anindya. It's interesting. However, I have one question. Like, it always bothers me. Like when patients are on, we have invasive, and sometimes we have like discrepancy, which is massive between the invasive and non-invasive. Although when we look at the waves, they look like good waves. So which one should we follow for monitoring the blood pressures?
Ideally, in that case, we do usually tend to follow the non-invasive blood pressure if it corresponds with the wave. Sometimes the waveform is ideal in the transducer monitor, but we don't pick up the ideal map that is intended to be picked up, maybe because it's a positional change in the line itself. So in those cases, as I've seen before in the department, we go with the non-invasive blood pressure at that time.
So, Anindya, I have a different view. Please correct me if there is any discrepancy. Okay. So, first and foremost, most of the time we insert our arterial line in the radial artery, and the radial artery, also being a small caliber artery, has a risk of undergoing vasoconstriction, or sometimes it can get shut down or blocked because of many clinical reasons. Okay, so if there are such similar scenarios, then, and if you have a strong suspicion that the waveform, although it is looking good, but probably if the artery must have constricted a lot, in such scenario, non-invasive blood pressure monitoring is helpful and very corroborative.
Yeah, I said the same thing. I was saying about going for the non-invasive blood pressure.
No. Let me complete it.
Okay.
But most of the time, invasive arterial lines are more accurate.
Okay.
Uh, they do tend to underestimate the what do you say? Uh, diastolic pressure, and sometimes overestimate the systolic pressure. However, the mean arterial pressure on both lines will always be the same. Okay, so overall, otherwise, always remember invasive arterial pressures are much more accurate. Okay, There are certain situations where non-invasive can become inaccurate. One is if your systolic pressure is below 80, or if the patient is severely bradycardic. In these two situations, do think twice when you're going to measure the patient's non-invasive pressures. And at the same time, uh, if there is significant edema or if you have an obese patient, non-invasive pressure will, how shall I put it, inaccurately reflect the patient's clinical status. Okay. Dr. Ferenc wanted to add something.
Yeah, hi. Can you hear me?
Yes, yes, we can.
Yeah, thank you for both of the presentation. Very good. Anindya, you showed a picture. I just like to drag your attention about one thing which we notice time to time when you insert central line. You showed me the central line. There was a picture on the central line which was stitched. Can you put that picture back on, please?
Yes, let me just get on the slides.
So it's very important if you're going to see it that the central line has to be stitched in a way that you just not only stitch the hub, but you stitch the both side of the line as well. So in four places you need to stitch the central line to avoid any sort of accidental removal because the patients are moving a lot. So if you find that slide, that would be nice. Yeah. And
Yes.
also, yeah, did you find it? No?
Yep.
Yeah, here we go.
This one? Yeah.
So yes, this one. So this is we don't tend to do this type of. It's a very advanced suturing technique. You don't have to do that, but please make sure that you stitch all four through all four holes. If you see what I mean.
Yeah.
So it's not only enough. Even if the central line is number one, you choose the right size of the central line for the insertion site, and then you please stitch all sides as well. It's very important when you do that. Also, in ICU, all the arterial line needs to be stitched as well, right? So it's again avoiding any accidental line removal. And just to add to the debate of invasive or non-invasive blood pressure monitoring, obviously it pretty much depends on the patient's clinical status. But I would tend to agree with Ameya that probably invasive pressure monitoring is a gold standard in any ICU patients. Please do not accept patients to the ICU without invasive pressure monitoring unless we say so, because it can be very, very much misguiding. Thank you very much. Thank you for the presentations.
Yeah. Any other doctor anyone have suggestions or questions? Anindya, again, very good presentation. Okay.
Thank you.
Yeah, I would always stress everyone that all our invasive monitors that we insert are really very precious, because if they fall out, then it is a big disaster. Sometimes these patients are on anticoagulants, they may be bleeding. On top of that, if our invasive line come out, and there are incidences, a lot of critical incidences where invasive line came off, the patient bled and became unstable also. Okay. So it is always, I will always stress upon fixing the line properly, suturing well, and dressing properly, and always ensure that your line will is in place also. There have been incidences where intraoperatively the central line has also come off, and we were not aware. This has happened many years ago in my training days. We were not aware why the patient's pressures are not improving despite giving high dose of inotropin. So these catastrophes can also happen. So always take care of your invasive lines. Cool. So thank you everyone. And thanks a lot to both Sharmaly as well as Anindya for that excellent presentations. Okay. And please do fill the feedback forms. Okay. And let's meet next week. Thanks a lot.
Okay.
Oh, Dr. Ferrick, you want to say something?
Yeah, just one more thing, because I can see the attendance is not really great. So these there has been a lot of effort put into this teaching, organized for you all guys. So attendance, we cannot make it compulsory, but please make all effort to attend as many of you as you can through the teams. Yeah, thank you
Yes.
so much.
Thank you everyone again.